things that Dan and Andy Epstein and I have been very interested in is expanding the capabilities of the university to conduct high-quality health services research. There are a tremendous number of data resources that have become available, and I want to explain one in brief, which is the Optum Insight Data Initiative. So in brief, we've acquired and have loaded on the data center, the LDI data center server, de-identified data from 60 million United Health Group members, data going continuously from 2000 to 2013. It was really neat how this came together. It's a consortium of the Shea Eye Institute, specifically headed up by Brian Vanderbeek, CCEB with Sean Hennessy, and myself representing LDI. So these three entities of the university really coming together to put out the fairly sizable upfront cost of acquiring these data and engaging Optum in the negotiations between the university and Optum on having us, getting us the legal right to possess the data. So this is very exciting and really is sort of a unique venture. And the goal here really is to have Penn investigators have access to these data to do high quality research. Again, just giving you a snapshot of what's in the data set. I don't pretend to be an expert in these data since I think there are no experts in these data. They really haven't been used to a tremendous degree in research as yet. Optum is a new initiative of United Health Group, really just formed in the last couple of years to make data sets available to the academic community. But again, briefly, we're talking about 60 million covered lives. United Health Group covers about 15 million Americans in any given year over that period of time. We have inpatient claims, we have outpatient claims, we have lab tests and lab test results. We have outpatient pharmacy prescriptions, again, from the entire cohort of covered lives. Data are linkable within the data sets, so we have de-identified patient identifiers, de-identified physician identifiers, de-identified hospital identifiers. You might wonder about the churn in a private health insured group, so the average member stays in for about 3 years. United Health Group has members in all 50 states, though the dominant portion of their coverage is in the middle of the country. We also have data on 5 million Part D customers of United Health Group. So just some rules of the road for what we need to do, or what rules we need to adhere to use these data. These are only for Penn users. United Health Group really does not want you to bring in your pharma grant to be doing drug studies on their data, so that is not allowed. We can do funded projects by externally funded, we can do externally funded projects by the federal government, by states, by foundations. However, Optum will want to be written into those grants as an extra data use fee. The cost of that is not nearly as high as using CMS data, for example, so I think that is going to be quite feasible. We have obligated ourselves to report to United Health Group how we are using the data, so we will be developing a system for just registering users and projects. We want to, however, lower the barriers of entry to getting access to these data. There will be a CCEB portal for CCEB folk, though I'm heading up the LDI portal. And so, again, the goal is to get as many people using these data as possible. Some other kind of snapshots. So we have 8 million hospital claims over a 10-year period, 1.2 billion lab results, 1.3 billion prescriptions. There's economic data in here. They, for a variety of reasons, which you might imagine, they don't want to report exactly how much they paid for each of these claims. They have, however, implemented, and you have to dig into the details to figure out, but what they call standard costs of inpatient encounters, drugs, et cetera, that are sort of an average cost across their system. Again, I will refer you to the voluminous material that they provided to explain the details of those calculations. 2.8 billion outpatient claims are included. These include the actual patient out-of-pocket costs, including charges, copays, deductibles, coinsurance. There's also encrypted provider IDs, so you can't link it to NPI data, but you can determine the specialty of the physician. You can also determine that physician's practice patterns within the Optum data set, since those numbers, we are told, are preserved. Again, this is sort of exciting for me because most of the data I've used in the last 10 years has been Medicare data, so information about people younger than 65 has been sort of a mystery. We have kind of a rich set of enrollee information that they provided, including basic demographics, the zip code link to U.S. Census education and income level of each enrollee, and very careful information on their enrollment dates. We also know what type of insurance, the variety of products that United Health Group provides, including HMO products, POS, et cetera. And so those dates of enrollment are provided, so you could actually study switching and effects in terms of utilization. There's a variety of interesting ideas that can pop up. So here's why the data are imperfect. I sort of call these things the Guy David limitations, since he identified these almost instantly when I told him about these data. They are, so unfortunately for health services research, hospital and clinician identifiers are encrypted, and we are prohibited from linking these data to other data sources such as the American Hospital Association data set or the NPI registry. This comes as a bit of a bummer to someone like me who likes to study hospital outcomes. Nevertheless, I think we also do have an opportunity to go back to Optum and ask them, for example, can they link our AHA data to their hospital identifiers? And they have been very upfront with their willingness to do stuff like that for us. There's no death data as yet. There is an opportunity, however, to buy death indicators as a one-off from your cohort, so you can go back to Optum and pay for those. We've not quite negotiated prices for that just yet. I do not think they have any intention of making that a huge barrier. Inpatient labs, inpatient medications, this is really sort of getting into the weeds, are also not included because those, of course, are not paid for on an individual basis by the plan. Also, Medicare enrollee data you have to still get from Medicare, so they had to actually extract those. It's illegal for them to sell Medicare claims, it turns out, outside, strangely enough, of their Part D claims. Again, just some real brief pictures, and then I'll close. So this is the age distribution. Again, I didn't know there were people between the ages of 19 and 64, but apparently there are. They actually do use health care. The 65 and older group, which is what I've done my entire career to date on, is actually a fairly small subset, again, because the Medicare enrollees are pulled out. So I've had some conversations, for example, with what are the utilization rates of 25, 26, 27-year-olds, very relevant to the conversation about the ACA. That kind of information could be mined. I mean, we were talking about nearly 10 million individuals in that age group. Here's the geographic distribution of the cohort. These are states, right, that maybe many of you have never gone to, such as Georgia and Ohio and things like that. This is the great middle of the country. United Health Group has a tremendous dominance in terms of market presence in places like Texas and Florida. So again, these are actually important states, and so but I was very interested in kind of this snapshot of the American population that United is in United's sweet spot. Here's the plan distribution. Again, very detailed data about this. Not so detailed data about the actual cost paid, so we're going to have to trust United Health Group's mechanisms for determining individual level cost. But again, they're very willing to open up about how they made these calculations, so I think we would be able to work with their folks who've developed their own regression models to assign a cost to each individual encounter. All right, so this is my last slide. So the process for data access is still being refined. However, the goal is to reduce barriers to access, sort of because we only make money if people write grants on this, and Optum also is interested in people writing grants using these data. They live in SAS data sets right now. So those of you who don't speak SAS, we are bringing on a data czar who will help with that conversion process. That person will start work in April. In the meantime, the minimum requirements we will need for people who are interested, you need to be an LDI senior fellow. Yes? He's here, the data czar. Data czar. Yeah. He doesn't know that he's the data czar, so thank you. Thank you. Robert Nathanson is our data czar. He is our new postdoc at LDI, so thank you. So LDI senior fellows sort of come through me. CC Beers should go through Sean Hennessy. Any ophthalmologists in the room should go through Brian Vanderbeek. Right now, email me, and then I'll put you off until Robert actually gets a job, and then he'll do all the work. So thanks very much.